Hey guys, thanks very much for coming. Great turnout today. So I decided to start the year off with underactive bladder, not a very controversial topic in the big scheme of things. I actually thought it was going to be like a cakewalk, grand rounds to prepare, but once I started getting into the literature, it's like the iceberg. There's a whole mountain of literature under there. The definition of underactive bladder, no one really knows what the definition is. There's so many concomitant conditions that go along with underactive bladder. It's a challenging thing for clinicians to wrap their head around, and for a guy making a 40-minute presentation as well. So hopefully we can make it clear as we go. And just to be clear, we're talking about non-neurogenic underactive bladder. The neurogenics we'll save for another day, although again there's a lot of overlap there as well. So the objectives of this talk are pretty simple. I want to define underactive bladder according to the International Continence Society definition. I want to outline the etiology, the pathogenesis, and the clinical workup of underactive bladder. I want to update the medical management of underactive bladder. And I just want to review the non-medical treatment options. And hopefully that takes us away. We'll just start with a little case. So this is the guy that everyone's seen in the emergency department. He's that old fella, comes in acute urinary retention. Emergency doctor orders the CT scan for us. Shows this big distended bladder. You can see the bladder on his belly. Foley catheter goes in, it drains a whop load of urine. And his labs are a little bit elevated. So we admit him to hospital and watch him to make sure he gets better. We do an ultrasound a few days later, and everything's looking better. Labs are looking better. Digital rectal exam's okay. So we discharge him home with a Foley catheter because he was in such a bad shape. And we also give him an alpha blocker, which is hopefully going to open up that bladder outlet. We try and let him pee 4 weeks later. Unfortunately, he can barely void and has a huge residual. Totally agree. Totally agree. So he does get a TURP after we lose some efficiency points there. And it was our chief resident Ryan Flanagan doing it, who does a huge defect. This bladder outlet is open. We know there's nothing left. There's barely any prostate tissue. Crystal clear day one, and we send him home with a Foley because he failed his trial of void. We try him a trial of void again, and he fails again. What are we going to do? This is a real patient. People see this patient. I know Dr. Patterson's full of them from the Yukon. So he gets referred to the Bladder Care Center, and we do some urodynamic testing, and we'll go into that a bit more, and it's consistent with underactive bladder. So the lower urinary tract. Quick review of the neuroanatomy of the lower urinary tract. We, of course, have the hypogastric nerves. Those are our sympathetic stimulators. Sympathetic receptors in the bladder. Those are, of course, the alpha receptors at the bladder neck in both men and women. And they're also the beta-3 receptors in the bladder that facilitates relaxation. There's also parasympathetic nerves coming out of the pelvic plexus, the S2 to S4 region. And, of course, that's the M3 receptor. That's the big one there, and that facilitates contraction. And then we have Onuf's nucleus, which is always a cool thing. Some people call it the spinal micturition center, and that's our somatic nerves with the pudendal, and they, of course, do the external urethral sphincter. So the goal of any person should be to have safe, socially acceptable urine storage without incontinence and the ability to empty at will. So some smart professor did a search with different search terms just to see, how hot of a topic is underactive bladder, and it's probably the lowest on the list of hot topics in the lower urinary tract symptomatology. You can see as you go up into geriatrics, there's a whole field of internal medicine built on that. So there's lots of studies there. Overactive bladder, that's sort of the opposite condition, sort of underactive bladder. It's got much more literature on it. So there's really a paucity of literature out there right now. So because it's sort of the reverse of overactive bladder, I copied this slide from the overactive bladder and just added to it a little bit. Underactive bladder is characterized by poor sensation in general, but not always. Also, sometimes you have overactive bladder symptoms coming in, those irritative storage symptoms. Sometimes you have obstructive voiding symptoms, those emptying symptoms that are there. Those are really the hallmark of an underactive bladder. And of course, there's incontinence that goes with it too. The overflow, but then it can come in any different flavor. Why should we care about underactive bladder? Well, it does lead to some morbidity, even though probably there's a good portion of people who can be asymptomatic with it. Urinary tract infections, we know that's going on. Stones are potential, bladder stones. Kidney injuries, not as likely because it's usually a low pressure situation, but possible. Acute urinary retention is definitely possible. And of course, decreased quality of life for both the patient and their family members and the caregivers who look after them. So the International Continence Society defines underactive bladder as detrusor contraction of reduced strength and or duration, resulting in prolonged bladder emptying and or failure to achieve complete bladder emptying within a normal time span. So that's the definition we're going to stick with. And if you get that, it's a syndrome. It's not one particular condition. So there's a bunch of different things that can cause this. So the etiologies of underactive bladder. A nice way to break it up is neurogenic causes and myogenic causes. The neurogenic causes are, of course, those parasympathetic and sympathetic fibers, maybe getting damaged over time for some other insults, such as pelvic surgery, abdominal perineal resection is one of the classic ones. Abdominal hysterectomy is another classic one that can cause those injuries. And of course, there's infectious processes. The myogenic theory has diabetes, as does the neurogenic theory. There's a whole condition called diabetic cystopathy, which we're not going to go into too much detail today, but that's a big cause of underactive bladder and overactive bladder to boot. But the real myogenic thing is this overdistension of the bladder, and over time, it causes bladder failure, so to speak. And of course, there's idiopathic reasons. Some people believe that underactive bladder develops as you age. It's hard to say if that's true or not. Many people disagree with that. Some people believe overactive bladder causes underactive bladder. Medications, we all know there's lots of medications that can cause urinary retention. And then there's this particular syndrome in ladies with polycystic ovarian syndrome called Fowler's syndrome. And what Fowler's syndrome is, it's a tight external urethral sphincter and tight pelvic floor muscles that don't allow good emptying. So over time, you get that myogenic failure. So the pathophysiology, well, neurogenic, pretty obvious. You have damage to the nerves. Myogenic, some sort of insult to the actual muscle and cells. And one theory is that you get relative hypoxia and remodeling from this chronic overdistension. And of course, there's the idiopathic, but then there's some more weird and wonderful theories. And I just wanted to go into them just to say how much we don't really know about this condition. So, and I think they're sort of neat to think about the theories themselves. So there's the aging bladder model. These people believe that, as you get older, there's structural changes in all parts of our body. We lose muscle mass, we gain adiposity, some of us lose memory cells. It's all different. And of course, there's altered biomechanics and altered physiology. So the bladder itself, we know there's decreased anticholinergic receptors. There's an increased collagen to smooth muscle ratio. The bladder capacity itself is often decreased, although some of it will be increased. And you can see as we go down there, ultimately it ends with impaired bladder sensation and impaired contractility. So then there's the overactive bladder to underactive bladder theory. This theory basically states that the bladder wall will thicken during all of the unnecessary contractions in overactive bladder. This chronic OAB leads to structural and functional changes in the bladder smooth muscle, and it's possible that those functional changes lead to underactive bladder over time. So you have to ask the question, could this condition be effectively cured by treating overactive bladder early? Quite possibly. To look at this a little more thoroughly, there's epidemiologic data that sort of shows this interesting condition called detruser hyperactivity impaired contractility. And as you can see, as you move up in age, this green wedge gets bigger and bigger, meaning that the bladder has more instability, but also more incidence of impaired contractility. So that sort of gives weight to the overactive bladder to underactive bladder theory. There's also this failure of homeostasis theory. We have central mechanisms that are very interested in regulating our entire body, and maybe it's just a disarray of these central systems that's actually causing our bladder symptoms that we're feeling here. And this could be the very same process that's going on for overactive bladder as well. And then there's the people who already have the detruser underactivity. If we're letting them get some of these sequelae of urinary retention, maybe it can create this vicious cycle here where you get the retention, you get the infection, this releases inflammatory cytokines that cause lots of fibrosis and just worsening conditions and decreased quality of life for the patient. So epidemiologic data is pretty weak for underactive bladder as a whole. Mainly, it's just not that well studied. Prevalence in men, anywhere from 9 to 48%. That's a pretty big range. Women, 12 to 45%. Probably people who live in nursing homes, maybe a little bit higher. Young people, maybe 10 to 20%, but people are just sort of guessing at this because it's just small little chunks of the population, and there's been no wide population studies to really see it. And it's also a condition that a lot of people don't know about. I thought this one was good for the oncology guys. Detruser underactivity is prevalent after radical prostatectomy. This particular study thought 41% of the patients they saw had detruser underactivity, and you can see how they defined it there, and we'll talk about that. This is a Korean study that looks at more epidemiologic data. This one actually had men being at about 40% and women being at about 13% for prevalence. But then when you look at this graph over here, you notice that there's all these concomitant conditions that go with underactive bladder, making a diagnosis of this condition extremely difficult. So one last epidemiologic study. This is the most recent study, came out in 2014. It's a Detroit study. It's a telephone survey, and the response rate was very, very poor. But 23% of respondents did report difficulty emptying, and maybe you have some symptoms of underactive bladder. But only 11% of them actually knew what that was. So, quick, brief urologic evaluation. You need a thorough history, of course, voiding function, past medical history, focusing on diabetes, surgeries, all that. Like we all know that. You need a physical exam. This has to be a little focused. You want to do your sacral dermatomes and a little bit more of a neurologic exam than we'd be used to doing. The bulbocavernous reflex is very sensitive, and you always want to be careful on our physical exam. We're talking about urinary retention here, so you always want to keep the Caudy-Corona syndrome on your mind. Post-void residual volume, we'll talk about that in a sec. Urinalysis is always just a good screening thing for anything we do in urology, and urine culture if appropriate. Labs, we should get baseline renal function to make sure there's not dysfunction. Glucose is also a good one in this particular condition. Voiding diary, there's no evidence for or against it. Sometimes it's good for patients just to have a good look and see what they're seeing. Quality of life assessments are very important in this particular condition because ultimately this is a quality of life condition, although it can be a life-threatening condition if they're getting a lot of these sequelae with the infections and stuff. Urodynamics is the gold standard for diagnosing underactive bladder, and there's many people feel that anyone who has any of these types of symptoms of lower urinary tract should go on and get urodynamic testing. And then cystoscopy, of course, to rule out any bladder outlet obstruction, and renal bladder ultrasound if you so desire. So post-void residual. The European Association guidelines say that ultrasound is better than a catheter, and the reason they say that is catheter is associated with more morbidity than the ultrasound. So ultrasound gives you a quick little thing, and it's more acceptable to the patient than an in-and-out catheter. But ultimately, what's normal for PVR is 500, 1,000, 50. We don't really know. It's, everybody's definition of normal varies. And yeah. That's a really good point. I didn't have anything on that, and it totally makes sense why that could lead to chronic problems with ladies. If we think about the relative hypoxia of just being distended for 36 hours. In urology, we think testicles a lot, and after 6 hours, those babies are gone. And they don't have it. I can imagine. So I put up a quick Uroflow just to show what a typical underactive bladder Uroflow might look like. This has the classic intermittency. You can see on the flow the voided volume just slowly goes over time. His voided time is 2.5 minutes. Most people, if they're standing in that toilet 2.5 minutes, they'd be getting pretty upset by now. So urodynamics, again, it's the gold standard, and of course we all know the basics of urodynamics. But what we're looking for on urodynamics to diagnose this condition is low detrusor pressure, increased capacity, typically. Delayed sensation is often present, and there's usually a slow delayed flow. So this is a pretty much a pure underactive bladder urodynamic slide. And as you can see, the patient is straining to void here. So there's lots of activity in the abdomen, in the bladder wall, leading to this not that much pressure buildup, surprisingly enough. We only get to as high as 19 right there to be able to void. And he only voided 300 cc, and his bladder has 600 cc in it. So again, this is a classic underactive bladder urodynamic study. This is that condition I briefly touched about with the overactive bladder to underactive bladder hypothesis. This is that detrusor hyperactivity, impaired contractility. You can see there's a leak episode right here, and this is the pressure in the detrusor right here. Very low the entire time, but there's a little bit of a spike here, which correlates with a spike in the vesical wall without the abdominal wall. So that's a true bit of an instability. So that's that condition there. And the reason that's important is we treat that condition differently. And no one really knows how to treat it, but often the standard thing is anticholinergic and CIC, going right too. So that's why it's important to have that condition on your mind. Urodynamic definitions of underactive bladder. This one I had a tough time wrapping my head around just because we don't do it very often. But ultimately, there's no ideal definition, and lots of researchers have been looking for an objective definition to be able to say you have it based on these numbers. Kaplan and his group said it's poorly sustained detrusor contractions less than 30 centimeters of water, less than 12 milliliters per second of flow rate. Maybe a lot of people would disagree and say it's maybe lower than that. Abrams Bladder Contractility Index, this seems to be the easiest of these algorithms to wrap your head around. It's basically just the detrusor pressure at the maximum flow rate plus 5 times the maximum flow rate. And I put in this little chart here. If you're less than 100 on that calculation, you classify as having weak detrusor muscles. If you're between 100 and 150, normal. And above 150, you have strong detrusor muscles. So hopefully we're all above 150. So treatment. There's no current guidelines or management consensus. And that's one of the challenges of doing a presentation like this. It's usually nice when you have that guideline right in front of you. But ultimately, it's pretty obvious what the goal of treatment should be in these people. We should prevent upper urinary tract damage. We should prevent urinary tract infections. Overextension is probably a bad thing in these people because, like that case that we heard about with the pregnant ladies with epidurals, it could lead to chronic problems. We want to decrease residual urine, which again is going to lead to bladder stones and other sequelae. And we want to improve continence if they're having any issues, because that's a real social concern for people. And we want to try and find a way to improve their quality of life without burdening them too much with treatment. So, treatment. Conservative, medications, of course, and really and truly, there's only 2 current ways to treat this. There's some other theories out there. You can either increase detrusor contractility or decrease outlet resistance. So with our fella in the case, we decreased his outlet resistance, but he's still having troubles. There's interventional stuff we can do, bladder drainage, neuromodulation, surgery, and there's investigative treatments that are out there that really are very far away from being clinically applicable, probably not even in my lifetime based on what I'm reading. So conservative. Much like overactive bladder, you need to educate these people about their condition. You need to tell them what's normal. You need to tell them about the condition itself, give them some good reading material. And of course, whenever we've seen a consult on the ward, we always want to make sure they're not constipated, do a medication check, and also make sure they're moving around, because if you're not moving, you're probably retained. We want to manage their expectations. This is one of those chronic conditions, and there's not a quick fix, unfortunately. And of course, no treatment may be acceptable. If these patients aren't bothered and they're not having any issues from incomplete emptying, then maybe you don't need to treat them. But certainly, you have to do that carefully, and they should have good follow-up if you're going to take that road. So, natural history of lower urinary tract dysfunction in men. Not many studies on this because we get them first. We don't want them to slip through the cracks. So in this particular study, looking at transurethral resection with people with underactive bladder that was not recognized, this particular study felt that there was no improvement in the symptoms, and there was actually increased chronic retention in the TERP group. So they thought you should be careful about TERPing these patients with underactive bladder in this particular study, but that again is controversial. Many people would say you got to treat that outlet first because that's one of our main ways to treat that. Next study, done by the same group, was just looking at detruser underactivity itself. And the natural history there goes untreated. They actually found there was 3 cases of acute urinary retention. There wasn't that many cases of infection. And needing TERP, there was only about 8 patients that went on to get a TERP at some point in time. So not the worst thing, but maybe we can prevent that somehow by recognizing those people sooner. And they did notice an increase in detruser overactivity with time, as well as that impaired contractility. So those patients, maybe their quality of life isn't as good as it could have been if we treated them sooner. Behavioral therapies, just really quick on this. Time voiding, double voiding, straining to void. People have to be careful to strain to void because that can cause pressure back up to the kidneys sometimes. That's the Crede maneuver. Crede maneuver is when you push on your belly. Valsalva maneuver is when you clench down, and you know, there's always the risk of popping a hemorrhoid or something like that there. So I mean, that's all over the literature. They say you should be careful, and you got to warn people about that. To be honest, there's triggered reflex voiding. That's more for the neurogenic patients. But if you stimulate a neurogenic sacral dermatome, sometimes they can get a voiding reflex. Lower urinary tract rehabilitation, biofeedback. The main thing there is teaching people to relax their pelvic muscles, teaching people to relax that sphincter. Pelvic physiotherapy is much the same. And then, of course, just good common sense. Stop smoking, lose weight, make your bowels regular, and wear pads. So medications, again, 2 main targets: increase detruser contractility, decrease outlet resistance. So we'll briefly touch on these. The bottom line with the medications is they're not very good for this particular condition. So we have a nice synapse there from a parasympathetic neuron going to the muscle cells itself. There's these nice muscarinic receptors, the M3 receptors there. I can't point. And then there's Bethanechol is there. That's a muscarinic receptor agonist. So that's one target. Problem is it's not very selective, and it can hit everywhere in the body at the same time. Another one is dystigmine. Dystigmine is a cholinesterase inhibitor, so it stops the breakdown of endogenous acetylcholine. Those are the 2 main treatments we have, and there's a couple other drugs in those groups, but those are the main ones that have research on them. So Bethanechol, this is the only drug that's approved for urinary retention, but the evidence for it is very, very poor, and patient tolerability is very poor. If you all remember back from medical school, when you have a cholinergic overload, that's that sludge syndrome you get where you're just oozing from everywhere. And some of these patients do get that, and they get abdominal pain, and it's just very, very uncomfortable. But I picked out 2 studies from this meta-analysis of these type of drugs, and you can see there in the far right column, both of them really show no significant improvement over placebo. And if you look at the side effect profiles on them, it may even be worse. So this is dystigmine, same study. You can look over to the right, there's no significant difference. And even this one showed a statistically significant increase in residual urine with dystigmine, if you can believe that. However, there are some studies that do show some positive effects with dystigmine. This one was looking at timing of taking the dystigmine, and they actually found that the maximum flow rate, post-void residual, improved in both groups. So there are more positive studies for dystigmine than for Bethanechol. So if you were to pick one, that would probably be the one to pick, but I don't believe that either of them are covered right now. So it's probably best just to stay away from these drugs unless somebody's really desperate. So in summary, there's no overall significant improvement in voided volumes. Post-void residuals or flow rates compared to placebo. Dystigmine might be a little better than Bethanechol, but the side effects are a limiting factor in these particular drugs.
Is there any work on intravesical drug administration?
There is some intravesical drug administration. Capsaicin or something. I forget. I didn't go into it too much because it's mostly theoretical at this point, and they're not doing it in practice. But there's a few studies out there with some intravesical administration, not of these particular drugs themselves, but some different agents. And the idea is to promote increased contractility with the intravesical therapy.
There are now ways to gain intravesical exposure for that to stay there and
Yeah. Definitely an area I think they will be looking at more. So there was one positive study here with combination therapy with alpha blockers and cholinergic drugs. This one used Bethanechol as well. And I just wanted to highlight this one because this shows some data on the alpha blockers itself for treatment of underactive bladder. The white box is basically the pre-period. The gray box is the post-period. And you can see that the alpha blocker group has an increase in Qmax is the flow rate, and an increase in a decrease in the PVR, as do all the categories. And that effect is most significant when you combine the medications together. So alpha blockers themselves, I always wanted to figure out, do alpha blockers work in women or not? Because you see that all the time, and there's a little bit of data coming out now saying that women do have alpha receptors, and yeah, it actually does. It does have a bit of a benefit. So if there is a lady with urinary retention, it's not wrong to put her on Flomax, unless of course she's that old lady who's going to get side effects from the Flomax. Then we should watch ourselves. But in this particular study by Chang, 33% of women responded and had an improvement in their objective findings. Which, 1 out of 3 people, is that a good response? Probably not that bad. And some studies show greater significance, some less, but that's about an average response. And then this is my one pediatric slide here. I just wanted to look. We use Flomax in pediatrics, and I didn't really know what the data behind it was. Does it actually work or does it not? And in this one, this is people who had high residuals with no obvious bladder outlet. They had tried the conservative measures. For 7 months, they gave them the Flomax, and they improved. And they actually tolerated it really well without any effect on their blood pressure. They say it's bladder neck. They say there's, like the studies are saying that there's alpha receptors right at the bladder neck, so that that sphincter that women have there, they say it relaxes it there. Correct. But it's such a spectrum. That's the hardest thing about it. It's so hard to tease them apart. And And when you're thinking of treatments for it, you just have to target. You only have the outlet, or you have the detruser itself. And some of the new research is looking at targeting the nerves with like gene therapy and stuff like that. But it's tough. It's a bit of a conundrum that way, just like you're saying. So these are some of the newer ideas out there. This is some experimental stuff. So prostaglandins, those are known to contract the bladder itself and contribute to a pro-parasympathetic environment. This EP3 receptor is a target that people are trying to look at getting. This SERCA is very exciting for gene therapy. It's a sarcoplasmic calcium ATPase or something like that. Basically, I believe it actually pulls calcium back into the sarcoplasmic reticulum. It's sort of counterintuitive, so that more is in there for releasing for a big contraction. So there's some neat potential targets, but the research on all of these is really in its infancy at this point in time. So there's lots of work to be done. Some non-medication interventions, just real quick. Bladder drainage. We're as a wise man says, we're catheter docs at the end of the day, and we need to know all about bladder drainage. We need to know about neuromodulation a little bit, and surgery. So bladder drainage. I wanted to look at catheters a little bit because we never really hear about them. So types of drainage. Intermittent catheterization, Foley catheterization, suprapubic catheterization, and I guess you could have nephrostomy tubes and stuff, but that's not bladder drainage. Intermittent catheterization, there's three main techniques: sterile, aseptic, and clean. And ultimately, this is the preferred management, and we'll go over some of the data why that is. Underactive bladder patients with tolerable symptoms and no complications may not want any treatment, which may be reasonable, but those type of patients, you would want them to have close follow-up. You wouldn't want them to be the Dr. Patterson specials. Reasons to initiate drainage, we've gone over that already. So intermittent catheterization. So sterile technique, we all know this. This is what we do every day in the hospital. Clean technique, that's basically rinsing under the tap, clean it with some soap, and you can reuse these catheters. You just have to store them quite safely. And then this aseptic technique is maybe a little bit better than the clean technique, but it's a bag, you don't actually touch it, so your endogenous flora hypothetically wouldn't get on there until you touch it down into your urethra. So long-term bladder management by intermittent catheterization in adults. There was a Cochrane database systems review in 2014 on this. They looked at 31 trials. As far as intermittent catheterization goes, there's no superior technique that decreases complications. They're all equally effective. There's no superior strategy, whether you should use the single catheter or the multi-use catheters. But a good thing I read, probably makes sense, is for people who aren't getting lots of infections at first, you should probably start with a clean technique because it's a little bit easier. If they're starting to get infections or starting to get complications, you can just slowly go up the grade, and then at least you save a couple bullets in your pocket for if they start getting sick. Intermittent catheters versus indwelling catheters. What's the data on that? Well, there's tons of data showing that indwelling Foley catheters that are left for a long time deteriorate the upper urinary tract. They cause renal dysfunction. They cause poor bladder compliance. They lead to infectious complications and all of the other. It's just not a good thing. So of course it's preferred to do intermittent catheterization, but that's not always appropriate for some people, and some people do need urinary drainage. Probably what they need is more frequent indwelling catheter changes when they do have those in. And I think we're better at doing that now than when a lot of these studies were done. So if you look at the actual data on that, indwelling Foleys in blue, you can see that many more patients with indwelling Foleys get pyelonephritis, vesicoureteral reflux, and hydronephrosis. If you look at intermittent catheter, which is the middle one, you can see that shows improvement almost across the board from spontaneous voiding. So really and truly, for these people, that is the safest way to treat things. So is a Foley or a suprapubic better? Well, they're about similar in complication rates, but suprapubics are more comfortable, and we've all seen that horrific-looking traumatic hyposphadia that would be nice to avoid if we could. So that's why if you're going to do a long-term Foley, it may not be a bad idea to do a suprapubic. And I was interested to see this. I always see people come into the hospital with elastic catheters in their bladder or their suprapubic site, and I never really realized why. I always thought just throw in a latex one, but it's actually there's data to say that it's decreased rate of incrustation if you use elastic catheters. So those people with chronic ones, I'll probably throw in elastics from now on. Neuromodulation. It's sort of it's a hot topic. It's been around for a while. It's sort of used to treat a whole lack of conditions and chronic pain in the pelvis and other stuff. No one really knows exactly how it works. I think we're getting a little closer to understanding it, but we're still not quite there. And there's this sort of new kid on the block, which is neuromodulation, but they're just placing electrodes in a different place on the pudendal nerve itself. And hypothetically, maybe that treats the bladder outlet a little bit more. So sacral neuromodulation itself, we've had a talk on this before, but it's the InterStim device. It's implanted through the back. Urologists are doing it. Nathan Hogue's getting trained to do this right now, and put the electrodes right on the sacral nerves and let modulation begin. So what does modulation mean? Well, again, it's not well understood what's going on. The effects are thought to be most attributable to sphincteric relaxation rather than actual detruser contraction, sort of signifying that this is a multifactorial issue. This really only works in people who have some residual bladder contractility. It's not good for people who have pure atonic bladders. They're not going to get a good response from this, and they're probably not going to get a good response from the medications either. Signals are sent on afferent nerves. They go away from the bladder first. They go mingle in the spinal cord where they may reset things to a more natural state. But they also go up to the pontine micturition center and to suprapontine areas where we talked about the mapping really briefly earlier. They may rewire things in the brain that sends down the appropriate signals. And there are some MRI studies coming out right now that are actually showing brain activity when the firing from the InterStim device is happening. So something is going on there. Patient selection is paramount for this. Idiopathic non-obstructive retention is the ideal candidate for this. That's that patient with Fowler's syndrome there. The high tone pelvic floor retention, that's another ideal candidate for this. And so on. So this is a study. I just wanted to highlight some of the results. So 1-year results of the InterStim device being implanted for a pretty low number here. There's only 38 patients who had what they would classify as retention underactive bladder, but 61% of those patients were able to stop using any catheters after getting the InterStim device implanted. Long-term results, 5 years down the road, 60 to 70% of them were using less than 50% of the catheters they were before. Some of them had to go back to using it, but still, life was better than it was before. Or was it? So this is another study. 72% of women were spontaneously voiding with a low post-void residual. However, this InterStim device was full of complications, mostly related to the device itself, and they had to go into a bunch of surgical revisions on it. So it'd be interesting to do a questionnaire and to see if this was truly worth the procedure for these people with how many surgical revisions they had to have.
What's the timeline on that? Like, how many years is that?
I think it was 10 years. I think it was, if I remember right. But it was a while. Yeah. So I mean, it's really not a benign procedure. It's really I was sort of shocked. I thought it was a bit safer than that. The leads migrate. Yeah. there's definitely some. There's this, I think it's going to start coming around again. It's like that whole cyclical cycle. Last year, a lot of my slides, this slide right here, this Cure Underactive Bladder, that was the first conference where they got experts in voiding dysfunction all together. And they basically had a conference on this, and they were talking about all the benefits, and they were just sort of, doing what a lot of we try to do here is try and get a center of excellence and get an international collaboration to actually address the discrepancy in knowing that this condition exists and not being able to treat it very well with the current treatments we have. So the second one is coming up in December in Denver this year. So there's people trying to move and shake on this issue. Pudendal Neuromodulation, not happening. There's no studies on it, but there's some anecdotal evidence that comes from Peters himself that basically says that they can salvage people who fail sacral neuromodulation with this, and they say it's easier to implant, better tolerated for the patient, and its real focus is it probably has some effects of the sacral neuromodulation, but it's mostly that outlet from what I understand of it. So I thought this was really cool, and that's why I did it. This is for the atonic bladder, and this is a plastic surgery. That people who do this, it seemed in the study, but this is a myoplasty, where this big atonic bladder they cover with latissimus dorsi, and then they put like a implantable pacemaker in it, and it actually contracts. And amazingly, 72% of the patients were able to completely void after this. So these are neurogenic people, but that's just unbelievable. 17 to 24 patients being able to void. It seems like that data is pretty unrealistic almost, but that picture looks really cool. So I'd love to see that surgery. Yeah, yeah. I thought it was pretty morbid. So cool, really cool. You can just like flex your lad and you'll be. I know. Seriously, they said that. It's not even a joke. I was like, I read that.
Shrug your shoulders.
That's right. Good excuse. Almost done. Stem cell therapy. I just wanted to touch on it just because it's really in its infancy right now, and getting into the basic science of it was beyond what I wanted to do in this talk. I just wanted to give an overview of this condition. But the bladder itself doesn't regenerate that great. It does, but not great. We all know stem cells are a hot topic right now, and there are some positive results in animal studies, but human modeling and more animal modeling is needed before we can figure anything out there. Gene therapy is cool because we talked about maybe they can figure out a way to repair those nerves in that diabetic cystopathy with all that peripheral demyelination. The SERCA gene is a target that they're going to start hitting up. And of course, there's regenerative medicine with what Anthony Natal is doing out there in Wake Forest, and maybe he can grow new bladders and put it in. That'd be amazing. But all this stuff, the only reason I just gave this all one slide is just because it seems so far away from being reality. But at the end of the day, this is pretty fascinating stuff if it comes to play. So conclusion, this is a very prevalent condition. I don't think we truly know exactly how prevalent it is. We really don't know much about this condition at the stem of it. Treatment options. All I knew before this talk was throw a catheter in it, and still my main go-to, I think. Conservative. Everyone should be offered conservative treatment when they don't. It's really time-consuming for urologists who operate such busy practices. But at the end of the day, if there's a nurse practitioner who can sit down with patients and talk with them, those patients they're pretty happy with the service they receive. Medications. We need something new. We need to hit those targets up. Maybe do some more intravesical treatments. Interventions. Catheter in it. And sacral neuromodulation is promising, not readily available, and potentially lots of side effects. And surgery is morbid, like we talked about, for those atonic bladders. So thanks to Dr. Nigro. He helped me out with this. And any questions?